Good evening, everyone. My name's Lisa Wood. I am the Pro-Vice-Chancellor of the College of Health, Medicine and Wellbeing, and I'm pleased to welcome you here tonight. I begin by acknowledging the traditional custodians of the land on which we gather here tonight, the Awabakal and Worimi people, and pay respects to their elders past and present. I extend that respect to all Aboriginal and Torres Strait Islander people here tonight. We acknowledge that this land has always been and always will be Aboriginal land. We honour the rich history, the traditions and the cultures of the First Nations people who have cared for this country for tens of thousands of years. We commit to learning from their wisdom and working together towards a future of mutual respect and understanding. I'd like to acknowledge that tonight, as our special guests, we have the Lord Mayor, Ross Kerridge, and a number of University Council members. I'd like to thank you for joining this evening for the first Looking Ahead lecture for 2025 in what is the 60th anniversary of the University of Newcastle, a very special year for us. Our Vice-Chancellor will share more about that with you in just a moment. But before I welcome the VC to the stage, can I please take a moment to acknowledge our medical and healthcare professionals and researchers who are with us in the room. The university has a wonderful relationship with the sector, in particular the Hunter New England Local Health District, and that's also through Hunter Medical Research Institute. As a university for our region, we don't take lightly our important role in educating the future medical and healthcare workforce. We proudly educate the most nurses who go on to careers within the Hunter New England LHD. Our staff and students run incredible local and rural health programs, and we lead the nation in Indigenous health education. These achievements are only possible with the contributions of the many people here tonight, so thank you. Now I'd like to welcome the University of Newcastle Vice-Chancellor, Professor Alex Zielinski, for an official welcome and to introduce our keynote speaker. Thank you, Alex.
Thank you, Lisa. I'd also like to acknowledge the traditional owners of the lands we're meeting on today. So well done, Lisa, with that introduction tonight. But to welcome everyone and thank you for joining us tonight. I also do give a bit of a special call out to our Lord Mayor and Ross Kerridge, Dr. Ross Kerridge, who's also a conjoint professor here at the university. So thank you, Ross, for also educating so many of our future doctors, and it's wonderful to have you here tonight supporting the Looking Ahead series. And as Professor Wood mentioned, it's the 60th anniversary of the university since its independence and foundation in 1965. So someone was telling me in marriage terms, that's a diamond anniversary. So that's wonderful. It's a year of diamond, a diamond year. So it's plenty to celebrate. It is a fabulous milestone. And our region has been really well served, I think, by the University of Newcastle. And it's been very much dedicated to serving our communities, committed to educating generations of students. And this year, I think we're going to tick over, by the end of the year, over 200,000 graduates over that 60 years, which is just phenomenal. And not only graduating, but also bringing new ideas and thinking into the world. And I can see there's a lot of very distinguished researchers here tonight, a fantastic panel we've got together. And you know, through the institutes like the Hunter Medical Research Institute, a wonderful partnership with the local health district and a university, we have a world-class institute, and we are leading to medical transformations and great outcomes. And I think tonight's lecture hopefully will inspire how we go to the next level. So I'm very excited about that. So it's a way of looking ahead for the next 60 years as we lay down. We look back at 60, but really let's look forward to the next 60. And I see that's why we value events like this, because it's not just a university event, it's an event for the community. That's why we hold it here in the conservatorium. We open it to the public, and we make everyone welcome. And because I think by building knowledge, we contribute to advancing the region and understanding what is possible. So with lectures like the one tonight. So we have a fantastic keynote speaker, and as I said, a fabulous panel of experts. And so our panel will help us understand the interwoven relationship between medicine and technology, and they'll share their ideas on how we can achieve the best outcomes for patients as we move into the future. It's a complex but very exciting topic, and I'm very keen to hear from our panel and our keynote speaker. To get started, let me please introduce tonight's special guest to deliver the keynote address, and that is Professor Benjamin Seet. A little bit about Professor Seet. Professor Benjamin Seet is the Group Chairman Medical Board and co-chair of the Academic Partnership Office for the National Healthcare Group in Singapore. He's an adjunct professor and serves on the governing board of Lee Kuan Yew School of Medicine. Professor Seet currently chairs or is a member of the governing body and steering committee of a number of research institutions, as well as various public organisations in this and also in the private sector. He's co-chairs the Experimental Drug Discovery Centre. He's deputy chair of the PrepVax program, and he's played a founding role in setting up the Skin Research Institute of Singapore, Rehabilitation Research Institute of Singapore, and the Asian Centre for Health, Behavioural Insights and Interventions. He was formerly Executive Director of the Biomedical Research Council at A*STAR. So those who don't know, A*STAR is Singapore's equivalent to CSIRO. It's their national science agency, and to be an Executive Director lead institutes that these are very prestigious leadership positions. He's also, and prior to this year, was the head senior leadership appointment at the Singapore Armed Forces and with the United Nations. So he's also served at a national level and globally. So we really are very lucky to have Professor Seet here tonight to address us. So distinguished guests, please join me in welcoming Professor Benjamin Seet to the stage.
It's a little bit embarrassing to stand with this guy behind me looking down my shoulders, but I'll try my best. So Lord Mayor, good afternoon, and to Professor Zielinski, thank you very much for inviting me to your beautiful city and campus to give this presentation. I've titled my talk, Medical Health. It's actually medicine and technology there, so that's a bit of a change. So health and technology. And I called it a Gordian knot. So for those of you familiar with Greek mythology, the legend goes that in the city of Gordian, there's this knot that's tied to an ox cart. And the legend goes that whoever manages to untie that knot would rule the whole of Asia. So many people tried, all failed, until Alexander the Great came along. He tried, he got frustrated, and he spliced a knot with his sword. So in a sense, I think that's what how I see technology in health. It is inextricably linked, but at the same time, I think it is not just a solution on its own, but brings certain challenges and problems as well. Let me try with my slides. Clicker's not working. If I could get some IT support. Okay, I'm just going to do that. I think it's hung. Nope. So this one doesn't work either. Could you? So maybe just a quick introduction to where I come from. I come from the National Healthcare Group. It is a public healthcare provider, and it supports the northern and central parts of Singapore. And within it, we have 3 hospitals, about 9 polyclinics. These are multi-practice general practices. And at the same time, also, we have 3 national centers, the ones for infectious diseases, skin, and mental health. Collectively, about 22,000 people supporting 1.5 million population. So very much similar to the Hunter Health System here. My role, I think I won't go through this because I think it was already covered during the introduction. But I was asked many times today, what do you actually do? And that was a question that I had a lot of trouble answering. So I'm going to sort of sum up to say, I'm not an academic, but I see myself as an observer. I observe trends, I follow trends, and I sort of do some crystal balling into the future. So that's the first part of the role. And the second part is to actually manage a portfolio. So it's a portfolio of research. When I was in A-Star, the budget was about $2 billion Singapore over 5 years, and that was a portfolio I managed to actually drive the outcomes that the Singapore government wanted. Now I'm in a healthcare group. Obviously, the budget's much smaller. But again, how do we actually make the right investments for the future? And that's going to be covered in my talk today. So what I'll be doing today is firstly to just very quickly go through the healthcare system in Singapore, a quick look at 3 technologies and how they will drive and change healthcare, and then subsequently, I'm no Alexander, but I'll try my best to take a little step at this knot that we're talking about. So when you look at Singapore, I think we are very fortunate to have a very good healthcare system. I think when you measure it using various metrics, we tend to pop up somewhere near the top. So we are very, very privileged about that. But what I think is most people don't realize is that we are probably the most efficient healthcare system anywhere because we don't spend as much. We spend about half of Australia and most of the OECD countries in terms of the proportion of government spending going into healthcare. It's about 4.5% of the GDP. But when you measure the total outcomes, I think it is probably one of the most efficient healthcare systems in the world. How we did that is another lecture on its own, so I won't be talking too much about that. But I think all that may be set to change because of 3 disruptions you're going to face. The first is that our population is getting older. So when you look at the stats, just in today, 1 in 5 of our population is above the age of 65. By 2030, it's going to be 1 in 4. And with an aging population, we're going to see a lot more cancer, strokes, heart disease, end-stage disease, and that burden of disease would go up. And I think the alarming fact is that while we do have one of the longest life expectancies globally, we spent the last 10 years in ill health. And that's a huge burden when you talk about the overall population demands. The next point is that, just like the rest of the world, just like Australia, because recently I think Australia was advertising to recruit nurses from Singapore, but just like the rest of the world, I think we do face a huge shortage, a projected shortage of health workers. Our estimates put it that by 2030, because of the rising burden of disease, we will need 35,000 more healthcare workers. And the fact that we have one of the lowest fertility rates in the world means that we will not be able to have our own children go into healthcare. And clearly, in terms of the manpower demand for health, this is not sustainable. When you look at money, you would see that the percentage, even though we spend so little on healthcare, it is going up. It has tripled from 2010 to 2019 in real-world dollars, so from 3.7 to 11.3 billion. And if we do nothing and keep healthcare on the current trajectory, it will triple again by 2030. So from 2010 to 2030, 20 years, 3.7 to $27 billion. And that's a 9 times growth. So I think that's the challenge that we face. If we were to sum this up, we are getting older, we are getting sicker, we've got less people to care for the old and the sick, and the cost of healthcare is not sustainable. And I guess that sets the stage of where we are. And the key theme that I'll be talking about today is technology the solution? If we have better technology, if we have more technology, is that going to be that Alexandra sought to splice this particular knot? I think we look to technology to do different things. Firstly, with technology, we can provide better treatments, safer treatments. We can deliver more effective healthcare systems. I mean, there's a lot of promise in terms of AI being to make our health system smarter, and therefore resources like dollars and people can be better employed. It can be a multiplier for the workforce, that if computers and robots and machines take over some of our work, it leaves doctors to actually focus on the sicker patients. And finally, also, I think with technology, we can actually empower patients to look after their own health and therefore have less patients in our hospitals. So that's a lot of promises, but I think when you look at technology, it is a double-edged sword. We can have better screening, but what better screening means is that there's going to be more patients for the hospitals. I remember when I was managing the medical classification, the grading of conscripts, that's like about 20,000 a year presenting for military training. There was a long debate about whether we do a very simple test, the electrocardiogram, for all pre-anesthesia. The test was cheap, but it wasn't the best test. And if we actually followed the best practices, between 1 in 15 to 1 in 20 will need to see a cardiologist, either have a scan, a 24-hour monitor, or go on a treadmill. And the overall cost and the burden to the cardiologist would be substantial. I think this is 20, 30 years later, we're grappling with the same problem. I mean, not many of our population believes in testing for blood in the stools, fecal occult blood. If we are successful in getting more people to screen, it also means that our hospitals will be overburdened with the colonoscopy workload. So more screening means more patients. Novel advanced therapeutics, we've seen gene therapy, cell therapies. It really complicates decision-making and really raises the cost. Higher survival rates, that has to be good, right? But ultimately, with some of the treatments today, patients that would not have survived 10 years ago, 20 years ago, now become patients that have to repeatedly visit hospitals. One oncologist told me cancer is going to be a chronic disease soon because we can actually control it, but it doesn't really go away. And finally, when we say technology can make our work easier, but it also generates a new workforce. I remember when I was a resident in the hospital, the only computers were in the admin department, and IT was probably like 5 or 10 people. Today, IT is the fastest growing cost factor for almost every modern hospital. So while technology is good, more technology is good, I think it comes with its own problems as well. I'm going to go through 3 case studies. The first, I think probably everyone here would say AI can solve certain problems. And I think when we look at AI, digital technology, the key intent is to digitize the front end and at the same time to make the back end, clinical decision making, hospital operations and efficiency better. For patient care, digital technologies can do things that we can't do today as a doctor in a clinic in the consultation process. You can measure behavior, lifestyle. You can monitor a patient continuously, remotely in his home, real time. And with the right tools and apps, you can actually provide nudges to actually change the behavior of the patient. And ultimately, with the data and the ability to analyze and make sense of the data, we can make decisions better. Lots of promises. We have more reliability, more efficiency, more humanity. That was an interesting one. How does an AI give a doctor a chance to be more humane in the clinic? I think when you look at some of the systems that are available already today for generative AI, the machine can listen to the consultation process, condense it, and then summarize it into the case notes for the doctor. So that's already available today. We are field testing that. And what it means is that you no longer have a doctor who sort of keeps typing the screen during the consultation, but is able to actually engage in face-to-face conversation with the patient from the start to the end. And that's something that doctors today don't have the luxury of doing. So we call it a gift of time to the doctor. And there was one study that compared human doctors to an AI algorithm, and almost everyone said they had more empathy from the computer than the human. I mean, for those of you that played with ChatGPT, you can ask as many questions as you want. It doesn't get frustrated to you. You can ask stupid questions. You can ask again and again and take 1 hour asking questions. But you can't do that with a human doctor in a busy clinic. So I think lots of promises. I've given some examples of how we use AI in our clinics. For skin, I think it's used for education, it's used for supporting diagnosis. That little thing with the different charts, it's for quantifying vitiligo, which is a disease of depigmentation of the skin. In the past, the doctor would probably do some scratches in a little chart and then sort of put a very qualitative assessment as to whether the patient is getting worse or better. Today, an algorithm can actually quantify it and measure. It's gone from 20% to 23% to 25%, and therefore it provides tools that the doctor would not have in the past. In rehab, I think particularly if you're going to treat patients at home, the ability for a smart, we call it intelligent rehab in the homes, to actually provide feedback to a patient, let's say in this case, going through upper limb rehab after an injury or a stroke. So the technologies, the promises are huge. But there are also challenges. So this is a real-life example of how we tried to bring real-world data into managing patients with schizophrenia. It's difficult because today doctors are limited to a physical consult. Information is either volunteered by a patient with schizophrenia or the family members. And there's only so much time that you can spend doing that. But with some of the tools today, you could have a wearable device paired with a mobile device, and that's where it gets complicated. Then you go into the Fitbit cloud if you're using Fitbit. That has to link with an Amazon cloud because that's where our health data resides. And you've got to deal with all the logistics, operations, IT integration, security to actually put that in place. And finally, it provides a report that looks like this one to the doctor who's got to actually make a decision. None of us will be able to interpret this chart on the left. There are some hot spots to say, obviously, these are little red flags. There are green spots which are good. But it's not only complexity in terms of the system and the setup, but a complexity in trying to understand and do something about the data that you get at the other end. So AI, lots of promises. I don't think we are there yet. And I think that's one alarming fact that the US FDA over the past 8 years has approved 1,000 AI apps or machines that have AI integrated into it. That's a compound annual growth rate of 73% a year. What's more alarming is that when you look at some of these challenges, it is very expensive. There's a lot of computational resources. It needs to be integrated with the EMR, the cybersecurity issues. And I think what is very alarming, and this was a fact that I only found out recently, that of this 1,000, only 3% went through a proper randomized clinical trial. Some were evaluated after implementation, but it also means that the same rigor that we hold for a drug, for a therapeutic, for a device, we're not doing the same for algorithms. And they're just sort of pushing them up by the tens, actually. And there are all these issues of training, reimbursement. If we put an AI app, who pays for it? Do we charge it to the patient? That's a huge sticky issue. How do you deal with the issues of trust? Ultimately, can a doctor trust an algorithm to be a partner in the clinic? Does a patient trust a doctor who relies a lot on the AI? I think these are issues that we will have to grapple with. And with trust comes accountability. And in hospital systems, with accountability comes liability. So how do we actually look at all these sticky issues in the clinic? And I've said many times when people ask me, is there an AI app that you really need? My answer is yes. It's one that can tell me of all the 1,000 AI apps, which one actually works best in the real world. So lots of issues. What are we doing about this in the National Healthcare Group where I come from? I think we have the advantage that we are the last healthcare group in Singapore to move aggressively into AI. So we got two other groups. In the National University Hospital, they did this as early as 8 years ago with the SingHealth looking after the eastern half of Singapore, maybe about 4 years ago. So we've got the benefit of hindsight from two other clusters that have tried to do this, and ultimately we have to put a lot in place before we actually roll AI in the clinic. The first is the most important, which is the data architecture by which, from which administrators, clinicians access clinical data. Obviously, it has to be anonymized. And obviously, if it's also for patient care, that anonymity will be removed as well. So I think that data architecture, the data protection, and access to this data is probably the most important point. And then, of course, there's a lot of other steps. We need to prioritize which projects to do, develop the models, validate them in the clinic, come up with the regulatory campaign, the business model, adoption, deployment, training, evaluation, before we scale up. Lots of work. Typically, if you start from top to bottom, it'll take 3 years. So the ability to prioritize which function, which clinical decision matrix that we would want to deploy first, that selection process is an important one. So we set up a platform called HEAL. It's still in its infancy stage, but it attempts to do all this in a systematic process, at least for our healthcare cluster. We have a university partner, the Nanyang Technological University, and what we've done is set up a center for AI in medicine, not to write algorithms and develop models, but to actually show that they work in the real world and to have a very systematic framework for evaluating AI algorithms in the clinic. And at the same time, to address issues like training, issues of needs, trust, ethics, which I talked about earlier. So that's AI. I mean, if you ask me, AI will be part of the future of medicine, but how we bring it in, how we adopt it, it's going to be very painful for anyone who starts. But subsequently, I think with a matter of time, it'll be fully integrated into clinical practice. The next area I'm going to talk about is precision medicine. So what is precision medicine? It's essentially looking at an individual's information and data, and today that's largely limited to genetic information, to actually make decisions into how better to manage his condition, how better to treat him, and also to aid with diagnosis. So it tells you the risks, the genetic risk of a disease. It may help you with a diagnosis, and also to know which drugs he or she would respond to. While it started with genomics, I think as the field expands, there are people looking at molecular markers, microbiome, immune markers, quantifying imaging, using digital data, and ultimately trying to put all this different data together, we call it multimodal data, from different sources to try and actually predict the risks or to support the treatment of a patient. But just like AI, this is very expensive business. There's a need to keep tissue, lots of tissue. So that's biobanking. The computational resources are equally challenging because you're trying to bring so many data sets from different sources together into a platform where you could actually, again, make sense of the data to actually help clinical decision making, as well as to address all these issues like how do you govern it, how do you protect it, how do you get reimbursement for it. And I think the last point at the bottom scares me the most, because for the companies in this industry, they project that the business will grow at 12% a year, which means that by the year 2032, there's $250 billion for companies to make, which means that if all this is put on health payers and patients, that's how much more the health systems and patients will have to pay. This is global. So ultimately, where there's business, obviously someone has to pay for it as well. And I guess when I look at precision medicine, it does make sense. It moves us away from what people used to call trial and error medicine, or to more precise evidence-based interventions. But the key questions I have is, will this create more work or less work? Who actually does this new work which doesn't exist today in our health systems? And who's going to pay for it? Does it save us money? What we are doing in Singapore, and I guess what we do in Singapore may not be replicable in other systems, but I'll just say that this is an example of how Singapore has approached this whole topic of precision medicine. 2013, that will be almost 10 years ago, I funded 2 programs. One was called Polaris, but essentially that was to look at how do we take sequencing that was largely something based in research labs into a hospital clinic. So I was looking at systems, I was looking at governance, I was looking at accountability. And then there was a pilot called Sapphire that looked at pharmacogenomics, which is people, because who have a certain gene, may react differently if they are exposed to a drug. adverse drug reactions, side effects of drugs are determined by our genes partly. So that was the first foray into precision medicine. Very, very basic, very, very early. But from some of the lessons learned, we decided to sequence 10,000 people. That gave us some insights and the willingness and also the justification to move to 100,000. And it's only by next year that we are going to go beyond 100,000 to sequence 10% of the whole population, which is where we think we are going to stop. So it's stepwise. As you learn from one step, you move to the next. As opposed to some other countries and organizations that start by saying, I want to sequence 1 million. Because if you make a little mistake with 1 million, you've got to go back to 1 million people to rectify that mistake. But I think what's equally important is that along the way, we set up national platforms. And I think, Francis, we're talking about platforms today. We set up Precise about 2 years ago. So this is a platform belonging to our Ministry of Health Holdings that governs the direction and the resources of precision medicine for the whole of Singapore. We set up something called Trust, which is, as the name sort of suggests, it's a trusted data reservoir for putting anonymized EMR data together with research data, lifestyle data from your Fitbits and your Apple phones in a single environment that's accessible to researchers and potentially to companies. Obviously, there are a lot of guts to actually have access to this data. And the very, very early exploration, how to use AI to make that whole system efficiency, to use AI more effectively with this data. So 2 lessons here, stepwise, and you take baby steps, and broader steps as you have more confidence. And the second thing, where it makes sense to centralize, Singapore is a small place, so you can say nationalize. We would want to do that. So what have we got from these insights? We know that if we were to use the same genetic risk panels that are used for Caucasian populations, most of the data comes from Europe or North America. We're going to miss 1/4 of clinically actionable genetic information. So we need to develop our own. If you look from right to left, the Chinese kid has a 4 to 7 times higher risk of familial hypercholesterolemia. That's a hereditary form of high cholesterol, which leads to early cardiac death as one of the potential complications. The Indian kid in the center holds a gene for HOCM, so essentially it's a genetic defect that causes the muscles in the heart to grow abnormally, and that puts the person at higher risk of a sudden cardiac event if, let's say, they're exercising in their 20s. And the kid on the left, the Malay kid, his sister, his mom, would have a higher genetic risk of having hereditary breast cancer and ovarian cancer. So these are insights, but again, insights, we have to act on insights, and again, taking that stepwise approach, Precise, that platform I was talking about earlier, is doing population-level experiments for different case studies. So familial hypercholesterolemia, we know that the gene frequency is about 1 in 140 people, which means that Singapore should have about 50,000 people that have this condition, but we only know about 9 to 10,000 of them, which means we're actually going to do a population-wide screening program to try and find the other 40,000. Whether this is cost-effective, we have no idea, which is precisely why we do a population-level pilot. It's ambitious, it's expensive, but this informs us on the next step. And we're doing the same thing for all the other conditions that the different kids sort of represented earlier. But a pilot is a study. Ultimately, the results of a pilot will have to be integrated into the healthcare system, and that will involve hospitals, clinics. We are setting up genetic screening centers to support each of the clusters. And after that, the evidence and the pathways to actually manage these conditions. I think most of our hospitals don't have enough genetic counselors, but genetic counselors are critical for this whole system to work. And again, I'm very clear that even if you've got good services, if we don't work with industry, it will not be sustainable. So even at a very early stage, we are looking at which partners we want to work with. The companies that manage data, the companies that do genetic screening, the ones that develop diagnostic tests, biomarkers, as well as therapeutics for this for these patients with these conditions. So we come up with a business development plan for NPM 3.0. That's National Precision Medicine in Singapore 3.0. That's the third phase of our precision medicine initiative. And I think this is a sense of how we are approaching a big technology area which could prove extremely expensive, but for which there's very little data as to how much impact that will have on the healthcare system, and whether it's going to save costs or make some companies very rich. So that's precision medicine. I'll move into the final of the three areas, cell and gene therapies. Very exciting. I think about 20 years ago, there's so much promise that stem cells could do everything from treat chronic conditions to extending longevity. But most of those promises have not been seen. But in the area of immune cell therapy, as well as in genetic diseases, we are seeing things that were absolutely not possible just 10 years ago. They all make it into the news. So BBC reported a kid from the UK coming to Singapore, getting CAR-T treatment, so that's using immune cells, his own immune cells. You grow them, and then after that you re-inject that, reinfuse it into him, and it cured him of his lymphoma. In the small print, if you look at the fourth row, it says, with the help of £500,000 raised from co-funding. So this is expensive treatment. In Singapore, just last year, we approved some of this sort of therapies and limited reimbursement. But a standard treatment for lymphoma or leukemia using this technology is about 500,000 Singapore dollars. And it has raised the cost of treating lymphoma 100-fold, just from one technology. Genetic diseases, that's more interesting. It's allowed us to treat untreatable diseases in the past. So the kid in that little photo there has spinal muscular atrophy. It's a degenerative condition of the spinal cord that progressively would mean that he would probably lose his ability to walk by the time he's 20s. He'll have difficulty breathing because his chest muscles will not work so well by the time he's 25, and many of them do not live past 30. But if he gets a gene therapy before he's 2 years old, he could be cured for life. That's the potential of it. But the challenge is that while this is a wonderful drug, it saves one kid, it costs $3 million. And even in a room of, I guess, people like us, how many of us can actually afford or have an insurance that's willing to pay $3 million to save the life of one kid? So these are tough questions. I mentioned earlier that I do some pro bono work with biotech companies in Singapore. Immune cell therapy. So this is unpublished data. So the graph on the right is a treatment using immune cell therapy for a patient with advanced nasopharyngeal carcinoma. The tumor was 90 centimeters or 90 millimeters at the time of presentation. That's almost the size of my fist. Typically, the prognosis is 3 to 6 months. At one treatment, this is in a clinical trial, 12 months later, the patient was not only alive, clinically better, putting on weight, and the tumor had shrunk from 90 millimeters to 20 millimeters. So this is, again, treating untreatable cancer. But the point is also that while the cancer has improved, it's still there. And while the patient is putting on weight, there is still cancer in the body. It's just smaller. And this is what I meant, that when you have a wonderful new miracle drug, it also adds patients into the system. And as more and more treatments of this sort are proliferated, we are going to get more patients who may be very sick or moderately sick, having to come back to the hospital repeatedly. Immune cell products, we've seen quite a number go into the market. Most of them are priced in the hundreds of thousands. Gene therapies, that was something I followed quite closely. Every time a new one was announced, I talked about spinal muscular atrophy. So US $2.1 million for one dose. Subsequently, treatment for beta thalassemia, which is a horrible problem in certain Mediterranean countries, certain Southeast Asian countries, 2.8 million. And then a drug called Skysona, because I think it was really hitting the sky for pricing, 3 million US. And then after that, another one for 3.5 million. And after that, I just stopped tracking because there's just too many, and they're all equally expensive. Why do drug companies charge so much? So when you look at beta thalassemia, what they did was they calculated backwards that in the US, if someone had beta thalassemia, they require regular blood transfusions. They will need treatment to remove the iron from their bodies. And at some point in time, they may actually need to have surgery to remove the spleen. And they calculated that over the lifetime of a patient in the US, it will cost them more than $3 million US to treat a patient with beta thalassemia. So 2.8 is actually a bargain for whoever has to pay that bill. So that's how it's calculated. And clearly, the mechanics of how drug pricing is done in the US is quite different from the rest of the world. But these are the current prices for these treatments today. What's scary is not this. What's scary is what else is coming. So these are so lucrative that we have another 2,800 cell therapies for different cancers and another close to 1,000 gene therapies for untreatable diseases. And I think the two charts, this is a bit old, this is about 2-3 years old. They've stopped tracking it this way, but I thought it was very illustrative. The ones in the center are the ones approved and in the clinic. The ones in the more proximal circles, those are the ones in late-stage clinical trials. And the ones that the agent is trying to come in, that's everybody else. And I guess when all this start, or some of this, or more of this, go into the clinic, I don't think there's any healthcare system in the world that can actually cope with the reimbursements for this. So this is a fractured pricing model. Coming to Singapore, same thing. Lots of people, universities, hospitals, all interested in trying to have a part of this. But I think what we are trying to do that is perhaps a little bit different is the fact that we are doing two things to try and nationalize or centralize it. So I guess when you talk about Newcastle, this is probably about trying to look at the state, trying to consolidate certain capabilities to manage this, what I'll call madness. It's biotechnology madness. One is a platform for discovery. So we have very firm gates to say, before a certain research or early discovery moves into the next stage. So that's the first gate. I won't go into the mechanics of it. And secondly, to actually have a central facility to actually support researchers, hospitals, and even early stage companies to actually manage that manufacturing process. We call that a national platform. And subsequently to look at how to do clinical trials, regulatory facilitation. One of these platforms is called ACTRIS. The words are tiny, but it says Advanced Cell Therapy and Research Institute of Singapore. But what it does is it takes the whole process of how do you develop a genetic drug, a nucleic acid, all the way from process development to make the batch for the clinical trials, all the way to clinical trials, as well as regulatory and facilitation for manufacturing. And I think what we try to do is we try to centralize the most expensive part, and then to actually put a very rigid system of controls as to who gets to do this and who doesn't. This is still early days, but at least I would say that it helps to contain the eagerness to actually do more and more in this space. So those are the three examples, and I think what I'll do in terms of trying to take a step at this knot is to, if you take a further step, why is there this drive for technology? Doctors want it. If you want the best doctors, the smartest doctors, many of them would not be too happy working with today's technology. They all want to be a part of tomorrow. And I think in any health system linked to a university, that's clearly a part of the mandate. I remember speaking to one equivalent of a director for health for one of the biggest cities in China. So he's got his key hospital, very much like HMRI in Newcastle. And he was in front of me and the hospital CEO, he was saying, whatever's the newest, what's the best, I want you to have it. Because once you have it, clearly it improves the standing of the state or the city, as well as of the hospital system. But if we take that approach, at some point in time, maybe 1 or 2 hospitals in China can do that. But if every hospital in China were to do that, then I think we'll see the next US health system in terms of GDP spending on health. It's not sustainable. What do patients want? Patients want to get better. They want to have more dignity if they do have a chronic illness. And more importantly, they have to afford whatever is being proliferated. And with some of those dollars that we see earlier, in fact, most people can't afford those sorts of treatment. And I guess the role, the responsibility of the health system is to take one step back, look at what doctors want, look at what the state of the technology is, what patients want, and ultimately try to make sense of the whole system. Just today, I got an email from our Ministry of Health that is trying to enforce across all hospitals something they call appropriate and value-based care. And they're trying to implement that as a system to ensure that as we adopt new technologies, it's appropriate for that health system, that health provider, for our patients, and that there's value at the end of it in terms of having good clinical outcomes for the people that receive these treatments. So that just came today. It was very appropriate for this conversation we're having. I'm going to take a step back now and sort of sum up some of the key learning points for Singapore and for the National Healthcare Group, which I think could be easily extrapolated in one form or another to other systems. The first is when you look at something expensive, something as big as AI in medicine, precision medicine, new technologies, it is important to actually have a strategic frame to say, this is how we are going to approach it, this is how we're going to resource it, and be very clear about the outcomes that we want to get from it. It is top-down, but at the same time, it is not trying to restrict research, because if there are wonderful researchers who can actually compete for grants and win them, we shouldn't deny them that. But at the same time, I think when state resources, when municipal resources, when university resources are used, I think we have to be very targeted about how to make those investments. So that's the first step. The second one, it cannot be driven by the technology trying to find an application. And we see this so much for AI in terms of the many applications that I have to review. It has to be ultimately driven by a clinical demand. And Francis, I think we were talking about trying to grow an industry. So at the state level, it's also driven by the economic opportunities of moving into a new field, which, if we are successful, obviously will go to fund the healthcare system through tax dollars and profits to the state. So driven by clinical demand, economic demand, which is a very Singapore thing. Zee, I'm sure you've faced many years of that. But ultimately, that has to be the driver. It can't be technology trying to find an application. The role of national platforms, I gave some examples, extremely useful because it saves dollars rather than every university, every hospital trying to compete for the latest and the best technologies. Doing it in phases rather than at one go. I illustrated that with precision medicine. Involving companies, public-private partnerships as early as possible so that it defrays public spending by tapping onto industry and corporate spending. And ultimately, just like that appropriate and value-based care that the Ministry of Health wants to put in, that we need real-world evidence to actually generate the decision-making and the subsequent investments. This is at the national level. I'm just going to two very quick slides to come down to my own organization in terms of how do I put all these things that I learned from the past in A-Star and in my other jobs into the healthcare cluster that I'm working on. And I think our research strategy is very simple. We've got 3 national centers, infectious diseases, skin, and mental health, and we do want to back them to become centers of excellence. We've got the oldest populations in Singapore, so we've got to deal with 2 problems. There are musculoskeletal health. We want to keep our old folks mobile. We want to prevent them from falling and breaking a hip bone or the femur. And also because of the rising burden of obesity, metabolic disorders, this is something we really need to grapple with because there's so much long-term sequelae from poor metabolic health. So 5 conditions. Cancer is not there, heart is not there, dementia is not there. But ultimately, it doesn't mean that they're not important. Of course, they're important. But because there are other groups in Singapore that are very competitive regionally, globally in those areas, it'll be not a worthwhile investment for us to actually focus on where others are already strong in Singapore. So we do things that are different. And the strategy itself is very simple. It's the 3 bars. We use technology to stratify our population, such that we can target the interventions on the people that benefit most from it, and ultimately measure that in terms of better population health. If we break this down into the next level, these are the technologies that we're working on, what we hope to do with those technologies, and ultimately the industry outlets for those technologies. And I think this is where it's important that if a hospital system were to try to do this alone, I think we'll be in trouble, because no hospital will have enough bioengineers, AI scientists, bench scientists to actually deal with all these problems. And this is where we have a partnering strategy. When I was introduced, partnership with a university is a key part of my job. And I think this is where we look at how do we partner nationally and internationally to be able to do this in a meaningful manner. I'm going to sum up with these slides. What I've covered today is a quick look at some of the problems Singapore's healthcare faces and how, using examples of how we are trying to adopt, embrace technology in a very commonsensical way to actually address some of these problems. Provided some case studies, ended with some examples, some lessons learned, as well as examples of how we used it on our health system. And I'm going to end with this quote. This is my final slide. A chap who calls himself a futurist. It sounds really sophisticated, but I think he put a statement that we tend to overestimate the effect of a technology in the short term and underestimate it in the long term. And I think we've seen this so many times with anything from the internet to stem cells to some of the other life-changing disruptions in medicine. So that's my lecture. Again, I thank you for inviting me to talk today, and I hope we can have an exciting conversation to follow. Thank you. I'll probably take this off.
Thank you so much, Professor Seet. That was very thought-provoking, and if you can stay on the stage, really highlights all the work that we have to do in the local environment. If you could take a seat, please, to join our panel. I'd like to now introduce our panellists, and first of all, we'll start with introduction of our moderator, and that is Dr. Alex Spencer. Come on up, Alex. Please welcome Alex to the stage. So Alex came to us from the Jenner Institute at the University of Oxford in the UK fairly recently. She's a bit of a dynamo. She leads the Vaccine and Infection Immunology Research Group based at the Hunter Medical Research Institute, and has done a lot of work in development of malaria and more recently COVID vaccines. So we're very thankful that Alex has joined as our moderator tonight. Thank you, Alex. Next, I'd like to introduce Laureate Professor Nick Talley. Come on up, Nick. So Distinguished Laureate Professor Talley is a neurogastroenterologist and Head of Discipline of Medicine at the University of Newcastle. He's also a past president of the Royal Australian College of Physicians. His world-recognised and groundbreaking research has resulted in nearly 2,000 publications, something that most of us can only imagine. And they're focused on gut health, and he's received numerous awards, including the Companion of the Order of Australia. Welcome, Nick. Next, I'd like to invite to the stage Professor Francis K. Lampkin. Come on up, Francis. So Francis is a psychologist with 25 years of experience as a mental health researcher at HMRI. She holds a prestigious NHMRC investigator grant for her pioneering research on digital mental health treatments. Francis is also currently the CEO and director of HMRI, an organisation that comprises 1,700 affiliate researchers across 19 research programs and 90 staff. She also holds leadership roles on several national health committees. And last but not least, I'd like to invite to the stage Laureate Professor Claire Collins. So Claire is a Laureate Professor in Nutrition and Dietetics, and she leads a research program focusing on precision nutrition. An internationally distinguished leader in nutrition and dietetics, Professor Collins has a research track record that places her performance in the top 1% of the world's most cited researchers in her field. She's published over 550 manuscripts and received the prestigious National Health and Medical Research Council's Elizabeth Blackburn Investigator Grant Award for Leadership in Clinical Medicine and Science. She's been recognised as an Officer of the Order of Australia for her contributions to nutrition. Welcome, Claire. So I will now hand over to you, Alex.
Oh, we're on. Okay, excellent. So we have 20 minutes. Do we like the lights like this? A bit too bright? It's all right. So I have the task of trying to keep us on track for half an hour. I mean, there's lots of great points that were raised. I have a few questions, but I feel we're going to head off those. I guess tying it all in together, I'll start with you, Claire. You've been an adopter of technology in your research. How have you kind of taken that on? What impact has that had for your research?
I'm just trying to tackle one part of what Ben talked about, and I guess it's the biggest gap that I see. So we have invented technology tools that can generate for people in real time information about what they're eating. We've linked it to metabolites that get expressed in urine and plasma. But my biggest frustration is that people don't get to use that in every day. So that's the biggest challenge we're working with, and I have brought a team together to try and apply for the funds. And I actually thought of your 4 pillars. We should actually add one that goes across, which is nutrition,
Okay.
for all of those. So I think it's kind of like trying to eat an elephant. And I accept that it's just going to be by one bite of a time. And it was something else that you said, Ben, you know, like one person can't do that. It's a team. So bringing people with the expertise. You need so many people. You need the engineers, you need the computer scientists, you need the technology transfer officers, you need to think about data privacy. It's almost too much to think about, but trying to do that and getting all the right team and accepting that, yeah, the elephant is just, we're just starting with the toenail, maybe, of the elephant, but we're going to eat that elephant.
Well, I might pass to Frances, because I think you've tackled a lot of this bringing things together.
That's very generous.
I mean, I guess what has been some of the hurdles, and are they hurdles that we can face, that we can overcome?
It's a really good question. Thank you for letting me jump in like that, because that's what we tackle in the same challenges in mental health. So we know we can build devices and we can build apps and all sorts of technologies to extend our reach as psychologists or as psychiatrists, and to extend healthcare beyond the clinic and the interaction. We know we can put therapists in the hands of people. We know we can teach people to be their own therapists by not being there. We know that digital tools are as good in clinical trials as face-to-face therapists, which is humbling. But our key is not actually a knowledge issue, it's almost a demand issue. People don't trust that using and engaging with these tools generally is as effective as engaging with a real life person in a clinic. And people don't trust and accept, and whether that's people with, say, mental health conditions or clinicians themselves, they don't trust that these tools are an effective way of helping them navigate and look after and address their own health and healthcare needs. And for me, that's the biggest thing. It's the trust and the will to use, because we can build all the tools, we can put all the infrastructure in place, and people still won't use them.
So that's a great segue, because then I get to speak to Nick, and Nick, you see patients on a regular basis. What do you think we need to do to get them engaged in this side of it?
Well,
Sorry, you're asking the gut person how to motivate and engage people?
No, I'm asking.
Go for it, go Nick.
It's someone who sees a patient on a regular basis.
Well, I think patients will engage, actually, and I'm struck by the change in the environment we're seeing clinically already. People are engaged with devices all the time. They have ChatGPT on their phone, they have other devices that give them information in real time. They have a wearable device like I'm wearing, which measures various biologically important issues. And some of them bring the material to my rooms as well to actually present it all to me in thousands of pages of information, which doesn't always help me. But what would help me and will help me in the future is AI. It's going to help me to interpret the mounds of data that we're now receiving and hopefully, cut through that information in a way that will lead us to better diagnostics, more targeted therapeutics. And I think that's the reality we're going to see, and we're already starting to see it. There are difficulties and ethical issues and other things we're going to face, but we're starting to see that already.
Okay, well then I might pass it over to Benjamin, because you've been in that space of generating data. I mean, I'm thinking about the cohort studies, the small, every step along the way is more and more data. How do we manage that data? What strategies can we put in place to make sure that we can store that data, we can generate that data, we can analyse that data in real time?
Yeah. Maybe it's about how do we choose the right projects. And I think I sit on a number of grant review panels, and today I'd say probably 1 in 3 proposals has the word AI in it, and it's probably moving towards 1 in 2 because everyone sees this as a bandwagon that they have to be part of. And I think when you use the analogy of developing a new drug, the companies are very clear. They have this thing called a target product profile that goes down to answering questions: who's going to use it? How is it going to be prescribed? Who's going to pay for it? And I think we actually may need to take that diligence and that methodology to actually evaluate AI apps and algorithms. And I'll say start with the end in mind. So if this is a face-to-face review panel, I'll just ask 2 questions. Who's going to use it? Who's going to pay for it? And if they can't answer, they don't get a grant.
That's a good point. But I guess I also think about AI, and I think about the information is only as good as the data that we have. And I guess one big concern with that data is its missing populations. I mean, you gave the lovely example here of the 4 different ethnicities. I mean, patients want AI data. We're generating data. How do we make sure that that data is proportional and is actually good and representative? And I get anyone can jump in on this one.
So that's to you.
We have to fund it. We have to support it, I think. And I think that's one of the exciting things about our particular region, in addition to Singapore, is that our 1 million people in the Hunter New England region are a demographic, social, cultural, biological snapshot of everywhere else in Australia. And so if we can take a lead from Singapore and work really hard together across our institutions with government to fund a big characterisation project. I'm stopping short of saying surveillance because that's a bit creepy, but if we understand who we are biologically, socially, economically and environmentally, and have access to that data, then it makes all of these other innovations a lot easier to implement, to be precise about, and then to evaluate the impact of. But we need to all do it together.
Yeah, and I think it's about making a start. So like we've worked with the UK Biobank, and that's criticised because it's very Caucasian. But if you want to achieve a proof of concept, then that's 300,000 plus people. And from there, you can start to look at, well, who's missing in that data set. But at least you're not working in the dark, essentially. You make a start, just like you said, Ben, you were looking for achieving a 10% population. Yeah. It's making a start.
I mean, one of the things we do also is to oversample minority populations and vulnerable populations. So when we talked about that 100,000, it's 60% Chinese who form up almost 80% of the population and 20% of the other 2 major races. And I think that provides us with the numbers as well as the diversity to make meaningful population level analysis.
So I guess it comes into the question, how do we engage that minority population to make sure they're represented? When Francis and I were talking before about there's actually a bit of scepticism or trust issue. So Francis, you get to take that one on.
So please chip in, everybody. But our conversation before this started was there's a big anti-science and anti-establishment mistrust out there, and I think it's growing, and I worry that it's growing. And I don't think we can take for granted that as government or university or academic or scientific or medical representatives that we do have the trust and the credibility that we might once have had. So short of us all, taking to TikTok and building, big profiles on social media, I think we need to understand what it means to connect with communities at their level, where they're at, in language and with information that's relevant to them, and that's not going to be served by us sitting in that beautiful building at HMRI and pontificating about what we might do with all the data that we have. It's actually getting out there and spending time in the community and taking the time, and it does take time.
So Francis, I can't help but dive in, having presented today some results from our Medical Research Future Funded trial, where we went to a minority population in our own region, which is upper New South Wales, around all the country towns west of Tamworth. And we did medical nutrition therapy consults on mobile phones. One person pulling over saying, "Hang on a minute," had to turn the tractor off. "Thank you, I could not have stopped to come into town for this intervention." So I see the opportunity is that we could go to people through some of our technologies where they actually weren't able to come to us. So it's really exciting, recognising all the challenges that you've also presented.
A historical strength of the Hunter has been population-based work. It's been a historical strength. It's been a major strength. Actually, being able to obtain large samples of the population, representative samples, is enormously valuable if you want to progress the science and actually then translate back into the community as well. It's difficult though, it's got more difficult with social media, really putting the brakes on people trusting research in the same way. We need to turn that around here. I think we can, but we need to turn that around here. And if we can do that, we could be absolute powerhouses in Australia, because not many places in the country could do this, actually.
Great point. And I guess then goes to engage the people, but also let we think about the workforce that's coming into this. Ben, you made a very great point about all the people. I guess my question is, what kind of workforce do we need to train? We have a wonderful partnership here in Newcastle between the university, the Hunter Medical Research Institute and the local health system. What should we be thinking about in terms of future and where we go in terms of training our workforce to make sure we are there and ready to take this forward?
Okay, so it starts with university. So we talk about clinicians. So we have probably about 18,000 clinicians in our health system, if we include the nurses, allied health workers, pharmacists, and so on. The new ones that enter the system are easy because you teach them in school. Let's say AI, all its implications, how to apply it. But when it comes to folks like me that have never used AI beyond playing with ChatGPT, we have to learn. And I think what we are doing is we start with the management and the leaders. So we start from the top, train them first, and then after that, a very expensive, time-consuming effort to actually educate the entire clinical workforce to be able to use something like AI in the workplace. It starts with probably a 101, a primer, but for the individuals that who need to actually understand it in greater detail, you send them for further training. But I'll say everybody needs to be minimally trained to a primer when you deal with some of these technologies here.
Yeah, I absolutely agree with Ben. So we put in a really fancy grant to try and tackle this for nutrition, and the place where we're starting is actually with the staff. Like, I worked clinically for a million years, and when you're so busy, how do you stop to look at how this technology stuff can work for you and your patients? So I do think it's leadership, but there are examples, like in your country, there are some examples in Australia, and like I said earlier, you can just get one win, and they'll tell the people in the other board, and they'll tell the people in our patients. So there has to be that strategy, but I think just trying to get the small wins and keep applying for grants. We all need more money. This is going to cost a lot of money to do this.
And the other thing that people could roll their eyes when I say this, but the thing that I loved most about my university education is that it taught me how to think in an open and curious manner. And also the importance of collaboration. I hated group work, but geez, it was really effective. And so I think regardless of the discipline, if we can make sure that through university and other education and training, we are modelling and providing opportunities to encourage a curious mindset and the importance of collaboration, then whatever's next after AI, I think we'll be prepping our workforces to embrace and to at least explore.
I think we are close to time. I'm trying to see through the dark. We got 10 more minutes. Oh, excellent. Okay.
Are there
10 more minutes.
questions from the audience?
Well, let's go back to the concept of big data, and how do we integrate all that data together, and how do we secure that data? What can we do to make sure people are confident of that?
Well, the integration's not going to be that hard. Well, perhaps not that hard. I think AI is progressing in a way that it will do that work for us, and that seems to be what's happening already. But protecting that data, the issues around data breaching, is a major concern, and understandably a major concern. Because even if you de-identify data, you can re-identify data anyway. We know that. There are technologies available for de-identified data to be re-identified, at least in part. And so there's a lot of issues about, will patients be prepared to provide these data? Do people want these data stored? Wherever you store it, it's vulnerable. What do we do about protecting everybody? Researchers, patients, subjects, academics, the community, everybody.
And it's interesting in genetics, because I'm a psychologist, so I'm about the least appropriate person to talk about genetics, but you're not just talking about your own data, it's the data of all the people who are genetically related to you. So you might consent to release that data, but you're releasing and providing access to those who are also in your family line. And so I think this is another thing that you mentioned earlier in your talk. I think there'll be maybe a new workforce that we need to help shepherd people through those decisions, and we call them genetic counsellors at the moment, but maybe it's the people who can sit with people and counsel them about all of the pressing issues and just to help people understand what they're signing up to do, including what might happen if there's a breach. So rather than perhaps understand or try to stop the breaches from happening or set up systems that are impermeable, maybe building workforces that can help people understand the concept of consent and risk, and those sorts of issues is as important.
Yeah, I think one of the fun things for the future are those multidisciplinary teams. So in the grant that I mentioned, it's called a Centre of Research Excellence for anyone who's into NHMRC language. But we've got people from design science, from the business school, from genetics, from nutrition and dietetics, from endocrinology, and internationally. And I think it takes all of those people to be working together, like no one in their real comfort zone, but like where we can get to, hopefully, is that integration of the knowledge we've already got. And that's what's really important. Like, people could be benefiting from some things at a relatively no cost. Nutrition does not cost $3 million a dose. Whoa. So we've actually got an opportunity to try and really develop cost-effective care. But I think, like, from what you've said, that's actually another set of researchers you need to be part of your team, the people who can do the cost-effective analysis. We actually have that here at Hunter Medical Research Institute, so yay, we're ahead of some other people. But it's all of these different people to come together to solve these big problems.
And I think ethicists have a real role here as well. So we're collecting data, should we be collecting all this data, and who should be making the decisions about what we do? So I think even our concept of extending beyond medicine towards other sciences and arts and ethics and philosophy, these are the teams that we need to help us navigate through these questions.
And I now forgotten where the question that one. But I guess we touched on this. We touched on the workforce. I guess bringing those people together. What are we doing in the Hunter to make sure that we are bringing all the aspects together and going forward? Talked about funding, about bringing in collaborations. How do we ensure that goes forward in the future?
Well, I think I'm not answering your question, actually, but I'm challenged by Ben's question, because Ben, you said like, who's going to use it and who's going to pay? And I think actually we really do need that front and centre at the start, which is why we need those cost effectiveness analyses. Because if we come up with a strategy, people are able to implement it, it's effective, we can use technology, and the health insurance companies are willing to pay, the government is willing to pay through our medical benefit scheme, then you've really got a winner. But I really like that you challenge us to think about that at the front, because you were mentioning about, you see grants and you say, who's going to pay for it? Yeah, you do see grants where people got a brilliant idea and you think, are people going to use it and who's going to pay? So that's in my new mantra, who's going to pay for it?
It's like we do see a proliferation of applications for AI-related work. And one of the things that I've observed is that there are many AI initiatives, even in my hospitals, but very few of them get beyond one department into the next because it's so customized and only this particular group of people could use it. And even few have gone from one hospital to the next. And to have something that is sellable, commercially viable across systems, across countries, are very few and far between. So a lot of the focus for AI research, even in health, is about developing a better and more predictive model without that thought of how is it actually going to be used subsequently. And I think that's the part that's missing.
Although I think it's very challenging. I mean, I was really struck by your comments about the cost of some of the new therapies that are emerging. Yet we're not going to be able to put those genies back in the bottle. Those genies are already emerging and there'll be more. It's very clear how that's going in the literature. And it's understandable. It's driven by people wanting to be treated and cured where possible, or at least controlled in terms of their disease processes. So it's very tricky because we're not going to be able to afford it all. There's no doubt about this. But who decides is the big question. Who really decides? And that's where I think we haven't got a lot of answers at this time.
And also, who can we motivate to engage in prevention so we don't wait until people are sick before they get their treatment, their high-cost treatment? And what are the levers that we can pull, and how can AI be used to get people to respond to those nudges so that we don't actually get sick people? We can intervene earlier in the trajectory.
Yep, so hopefully we can bring this all together. We can have an efficient healthcare system like Singapore. And I mean, I guess it's going to be complicated to do this at a national scale, but we have the benefit here in Newcastle of being local, and we can all come together as a collective to really work towards that. And I think that was the wrap-up for our panel discussion.
Maybe I should just end with
you get the final word.
No, one optimistic note on cell and gene therapy, in case it's just stopped across the whole campus. Is that I think when I look into the future, just like any new technology, the cost of goods will come down. So there are groups in China, I mean, I do follow what's happening in China very closely, that can bring that $500,000 treatment to $50,000. So that's a tenfold less. And there are new gene delivery technologies that could potentially bring that $3 million bill down to $300,000. It's still expensive, but like all technologies, it's expensive when it's in a lab, but ultimately when it comes down into the clinic 10 years from now, it could be much more affordable. So there's an optimistic note there.
Yep. Great to end on an optimistic note. With that, I just want to thank all the panel members. Thank you for your openness and discussion, and I'll pass back to Lisa.
Thank you. Thank you.
Thank you, Alex, and thank you to our panel. Can I please get another round of applause for Ben, Francis, Nick, Claire, and of course, Alex. Thank you all for joining us here tonight, and I hope you enjoyed the discussion as much as I did. We've had some really interesting insights into the capacity of medical technology to deliver better, safer treatments, more efficient processes, more effective patient-centred care, and of course to increase access to healthcare. All very important insights, and also we've been really privileged to hear about how Singapore has done it and how we might be able to use that as a model in our ecosystem. We really enjoy hosting the Looking Ahead lecture series. They're a way for us to share our thought leadership and also the amazing work that some of our teams are doing at the university. Tonight is the first of these events for the year, but we are also lining up a series of events across 2025, so I hope you'll be able to join us again. And in fact, if you'd like to know more about the upcoming series, there's a QR code that you can scan to register to find out and continue to receive information about the upcoming events. They're always wonderful nights, so I hope that you'll be able to join us again. This brings us to an end. For those in the room, please join me and the panel for some more discussion and refreshments in the foyer. Thank you and good night.